everyone. My name is Victoria Reynolds Vaughn. I'm one of the third-year ER residents here at OSU. We're so happy to have you guys here in the ER. We hope you have a great time. We hope you learn a lot and get to see a lot of exciting things. And we also hope that these lectures are helpful for you. So I'll go ahead and start with the abdominal pain for the ER clerkship. I'm sure Dr. Gardner has explained that each resident and some attendings volunteered their time to do these lectures, so there are certain parts that we all covered. Specifically in the abdomen, I think it's divided into just regular abdominal pain and then abdominal pain for females, so they're kind of split up in that manner. Specifically in this abdominal pain lecture, we'll be covering aortic aneurysms, appendicitis, bowel obstruction, cholecystitis and cholelithiasis, and diverticulitis. This is one of the most useful lecture visual images for me to use. I still have this picture in my head when I go into each person's room with abdominal pain. I know we saw this in first and second year medical school, but it's important still persists throughout your clerkship and even residency. In the ER, when you see someone with abdominal pain, your first thought should not be what is the most minor thing this could be, but what is the absolute worst thing that this could be. Or another way to phrase it be like, in what quadrant are they having pain? And then what is the thing that can kill them if I don't rule it out today? We have lots of things that are not necessarily covered in this lecture that of course you need to be familiar with medicine as its whole, but for the purpose of this series we'll just cover some of the main ones. Abdominal pain is actually the most common chief complaint in the ER. Our clinical suspicion for serious disease is important for patient in high-risk groups. One of the most high-risk groups that we see all the time in the ER are elderly patients. And in fact, abdominal pain in elderly patients can have a mortality rate ranging from 12 to 50%. So this is a very serious complaint, especially for the elderly, but also among children and everyone else. There are three different categories of abdominal pain. There's visceral, parietal, and referred pain. Visceral pain, which we learned briefly about in the first and second year, can be due to obstruction, ischemia, or inflammation. That can cause stretching of those unmyelinated fibers that innervate the wall and capsules of organs, leading to visceral pain. These are actually localized based on their embryologic origin, so lots of times people will come in complaining of pain that's felt in the midline, even when they have other things that might be localized to one side or the other. Then there's the parietal pain, which is an irritation of those myelinated fibers that innervate the parietal peritoneum. Parietal afferent signals are sent from specific areas of the peritoneum, and that pain can be localized to the dermatome, superficial to the site of the painful stimulus. And so this relates to visceral pain in that as this underlying disease progresses, your visceral pain turns into sort of parietal pain oftentimes. And then, of course, referred pain. This is the pain that's felt at a location distant from the diseased organ. So you have your developmental embryology leads to anatomically contiguous organs that share the same segmental innervation. And so referred pain generally is perceived on the same side as the involved organ. In the ER, as I discussed previously, our initial test that we think of in our mind is this patient sick or not sick? In that initial evaluation, we're determining the urgency and method of our diagnostic approach. Number one, we look at the patient acuity and their vital signs. Are their vital signs sick, where they're going to require immediate intervention with fluids or blood, or are they stable vital signs? And then from there we discuss, whether we're going to start resuscitating or we're just going to continue with our evaluation. And then after looking at those things, we look at their risk factors. Do they have special conditions or risk factors that affect clinical risk or mask the disease process? The first thing we're going to cover today is aortic aneurysm. With aortic aneurysm, the most common chief complaint in patients who are found to have a ruptured AAA are abdominal pain, back pain, or flank pain. And this can also be just like rapidly expanding abdominal aneurysms as well. This is a commonly missed diagnosis because lots of times these patients can present, like I said, back pain or flank pain, and can present with symptoms that are like renal colic, that can be like pyelonephritis, diverticulitis, bowel obstructions, GI bleeds, or back pain. Of course, the prevalence is more common in Caucasian males with a history of tobacco abuse, CAD, and age greater than 60. The most common location for an aortic aneurysm is between the renal and iliac arteries. The normal aorta size, the diameter, is approximately 2 centimeters. Lots of times in the ER, when we CT someone's abdomen and pelvis, we find that they have a small aortic aneurysm, and we describe these as less than 5.5 centimeters. Some of these are asymptomatic and can be discharged home with close follow-up, but anything that is a new finding of an aortic aneurysm greater than 5 centimeters with abdominal pain or other symptoms means we consult TCV. These patients, like I said, often present with a diffuse, nonspecific abdominal pain. Of course, imaging, CT is our gold standard, but due to the usefulness of our new ultrasounds, they can often be seen on bedside ultrasound depending on the size of the patient's abdomen. The key point for lots of these is unstable patients who are very hypotensive or very tachycardic should not be sent for imaging. Our initial treatment for this patient, along with most of our unstable patients in the ER, are our ABCs. We're going to stabilize them. Is their airway intact? Is their breathing intact? Is their circulation intact? Establishing large bore IVs, and then ultimately surgical intervention, because this is not something we can handle by ourselves in the ER if it's ruptures. Questions that you commonly encounter on your test will be, for example, a patient with midline abdominal pain and a 60-year-old male with a history of smoking, a history of coronary artery disease comes with midline abdominal pain. He describes it as sharp. He reports that it radiates to both sides of his abdomen. You palpate his abdomen and there's a, midline abdominal mass. Sort of like, what are your next steps? So you think, I can do an ultrasound. I'm going to go ahead and start putting IVs in this person. So lots of times that's a presentation of someone with an aortic aneurysm on the test specifically. Next is appendicitis, which we're all familiar with. It's one of the most common atraumatic surgical emergencies. It's actually most common during the 2nd to 3rd decade of life. And in pregnancy, it's the most common non-obstetric surgical emergency. Its classic presentation is vague epigastric or periumbilical pain, plus or minus nausea, vomiting, anorexia, fevers. So, of course, appendicitis pain is generally located to the right lower quadrant. When we think about things they ask us on tests, normally they'll say they have guarding, they have rebound. However, these have high sensitivity but poor specificity. The classic board finding for these are pain over McBurney's point. Other things that they can use to describe appendicitis on the test that are important to review are the SOAS sign, the obturator and Rosling signs. These are poor predictors, but are important for board review. For appendicitis, one of the most important things in the ER is your differential. There's more things than just the appendix in your right lower quadrant, obviously. So we have to think about testicular and ovarian etiologies. If they're children, we think about performing an ultrasound versus a CT to spare them the radiation. And in young, thin, very thin females, an ultrasound can be useful as well. The normal appendix is less than 6 millimeters and compressible. As an appendix becomes inflamed, oftentimes it increases in wall thickness, and an ultrasound can sometimes determine if there's a fecalith present or if there's flow present, and this can be used as an adjunct for aiding in your diagnosis. Of course, a CT with contrast in some of our older patients is useful because it helps us to evaluate alternative diagnosis and can lots of times see large things like ovarian cyst, things that we would have missed otherwise. And then, of course, in our pregnant women, to not expose the fetus to radiation, MRIs. Other adjuncts for diagnosis that the boards will give you, their CBC, BMP, CRP, UA, and of course the HCG. For our disposition, if you have a high level of suspicion but negative imaging, lots of times the boards want you to go ahead and call surgery. If you have, a patient who had epigastric pain that after 2 days radiated to the right lower quadrant, they have severe pain there, they have positive psoas McBurney's sign, that's someone the boards is saying like they have appendicitis, go ahead and call a surgeon. In pediatric patients, same thing. If you're concerned about appendicitis, we go ahead and admit those patients for serial abdominal exams. And of course, for every patient, since abdominal pain is on a spectrum of illness, we have them return in 12 hours for abdominal recheck. Of course, the treatment is definitive and is an appendectomy. Next is a bowel obstruction. These patients present with acute abdominal pain that occur when the flow of intestinal contents is interrupted. Oftentimes, the small intestine proximal to the obstruction dilates, which leads to their nausea and vomiting and inability to tolerate PO intake. Etiologies. Patients who've had history of multiple abdominal surgeries, strictures, irritable bowel disease, or malignancy. The most common cause of small bowel obstructions are adhesions, whereas the most common cause of large bowel obstructions are malignancy. Bowel obstructions, like you said, are sort of a twisting, or where something has trapped that bowel and it's sort of twisting around on itself. In a partial obstruction, small gas or liquid stool can pass, whereas in a complete obstruction, of course, no bowel contents are passing through. Strangulation of the bowel can occur, where you have bowel wall edema that compromises perfusion to the intestine and necrosis occurs. The presentation of these patients are often nausea, vomiting, anorexia, lack of flatus or diarrhea, as well as abdominal distension. They can have, on the board specifically, they'll tell you things like hyperactive bowel sounds, peritoneal signs. The board sort of likes for you to go, the first line is an x-ray, where you have air fluid levels in the small bowel or dilated loops of small bowel. However, these cannot definitively rule out a small bowel obstruction, and CT is your imaging of choice for diagnosis in your stable patients. Treatment, of course, we look at our ABCs. And then secondly, nasogastric tube placement, serial abdominal exams, and surgical consult. The NG tube, its purpose is to lead to GI decompression, because lots of times just releasing some of the pressure superior to the obstruction allows for the bowel wall to relax, and sometimes these resolve on their own. Of course, disposition to the OR if this is strangulated or perfed, and then to the ICU for unstable patients. Next is cholecystitis, which is an inflammation of the gallbladder secondary to gallstones or infection. Of course, as we remember, bile flows from the gallbladder down to the cystic duct, into the common bile duct, and ultimately into the duodenum. So any interruption at any of these pathways can lead to pain. These patients commonly present with right upper quadrant abdominal pain, colicky in nature, common after meals, and can present plus or minus with nausea, vomiting, and fever. Our diagnosis, as opposed to CT with most of our abdominal pain, the ultrasound is the preferred test and can establish cholelithiasis, which is just having gallstones, versus cholecystitis, which would be an inflammation of the gallbladder. Another differential to consider in this right upper quadrant pain, of course, is ascending cholangitis. Our treatment would be surgical intervention and broad spectrum antibiotics. For ascending cholangitis, this has a very high mortality in the ER. This is oftentimes found when just investigating for right upper quadrant pain. You have Charcot's triad, which presents with fever, right upper quadrant pain, and jaundice. And then Reynolds pentad, which is Charcot's triad plus altered mental status plus hypotension. Essentially, it's a bacterial infection of the biliary tract as a result of that obstruction. And then your treatment is broad spectrum antibiotics and ERCP. Then we have diverticulitis. Lots of people have diverticulosis, which is an outpouching of the intestinal wall. It's most common left-sided and can oftentimes present with painless lower GI bleeding. It can progress to diverticulitis, which is an acute inflammation of those diverticuli that can lead to pain and possible microperforation. These patients present oftentimes with left lower quadrant pain, fever, change in bowel habits, nausea, and vomiting. Diagnosis: CT imaging is most reliable. For disposition, there's something called the Hinchey classification, which is a scoring system for mild diverticulitis to purulent peritonitis. Lots of times these patients, you're going to be giving them antibiotics to cover gram-negative organisms and anaerobes. Of course, treatment, surgical intervention, bowel rest, IV antibiotics, or if they're able to go home, PO antibiotics. The Hinchey classification essentially has 6 different levels, like I said, ranging from mild clinical diverticulitis to a confined pericolic inflammation, abscess versus retroperitoneal abscess versus, like we talked about, just purulent peritonitis. Keywords to remember during testing. For you guys, these I just kind of committed to memory, and they're important even in my practice to this day. Aortic aneurysm, nonspecific abdominal pain, an elderly male with a history of smoking with a palpable midline pulsating mass. For appendicitis, right lower quadrant pain with anorexia or nausea or vomiting, who has a positive McBurney's, psoas, heel jar test. Cholecystitis, right upper quadrant pain that's just worse with eating. Ascending cholangitis, new jaundice, right upper quadrant pain, nausea and vomiting, plus or minus altered mental status and hypotension. For diverticulosis, painless lower GI bleeding, specifically pain in the left lower quadrant, or specifically with a history of diverticulosis. Then diverticulitis is the left lower quadrant pain, plus or minus a lower GI bleed. These are my references. Thank you for your time and good luck on your test.